Understanding the biopsychosocial impact of trauma. On the first slide here, you see some statistics that were gathered roughly about 10 or 11 years ago involving trauma in American children. They show that upwards of 3 million children were suspected of being victims of abuse or neglect. In addition, nearly 4 million adolescents have been victims of serious physical assault, and almost twice as much or more have witnessed an act of serious violence. I want to freeze at this particular point to also point out that when we're discussing trauma, whether it's in children or adults, what has been discovered in many studies over time is that when you ask individuals what was the genesis of their trauma, a majority, and the statistics in the adult population roughly are geared towards 75 to 80%, will report that their traumas were from things that were witnessed as opposed to things that actually happened directly to them. In 1998, also 92% of incarcerated girls reported sexual, physical, severe emotional abuse while in childhood. And then finally, up to 10 million children witnessed the abuse of their mother. Up to half of those are victims themselves. With regards to post-traumatic stress disorder, by that previous example, it should not be surprising that we have such extensive percentages of post-traumatic stress in the general population. These are conservative figures dealing with upwards of 14% in general population, and we might add is very low. And it's low because the disadvantaged groups don't necessarily report themselves to be counted in these numbers. So we know that the numbers are significantly higher. We also know that trauma victimization studies show that a prevalence of upwards of 98% of post-traumatic stress disorder in people with serious mental illness. What does this say? If you are a mental health treatment provider and you are interviewing someone with a serious mental illness, the diagnosis of post-traumatic stress disorder should lay very, very heavily on your mind and in your assessment. But if we're going to treat this particular disorder or any disorders involving trauma, we have to take into account a couple of things. The first thing we have to take into account is that their nervous systems are not necessarily at the point where they need to be. Now, what do I mean by that? What I mean is that for a majority of us, we sometimes use that erroneous analogy to say to the people we work with, oh, is that what your trauma is? Oh, well, I've had serious stuff happen to me and I'm still good. Well, you understand our nervous systems respond in different ways to different levels of trauma. So one is we have to take into account that everyone is different and their nervous systems respond differently. Secondly, is that the social environment cannot contain that dysregulation. What that means, in the United States, we have an old analogy from Africa that says that it takes a village to raise a child. I can remember way back when the community I lived in was an all-encompassing community. If I were to ride my bike to the other side of the community and I did something wrong, the person who I did not know, was a total stranger even to my parents, had the right to pull me off my bike, beat my butt, which didn't end the system there, because then they would pick up the phone and they would call my mother, who then would say, send him home. And by the time I get home, I'm now ready for the next level of punishment, which is directly from her, followed by the tertiary component that says, wait till your father gets home. What you learn from this is that there are consequences to behavior, and it was an extremely modifying component. Unfortunately, if we look at society today, that has long since been eliminated. Now, what Shankoff and Phillips did was take a look at some core concepts. And the first core concept talks about how kids develop. And it says that they unfold in terms of development along individual pathways. Well, that's not shocking. Everybody develops differently. But these trajectories or these developments are characterized by things that are called continuities and discontinuities, as well as transitions. What does that mean? It means, folks, that as a population, as a people, we are inconsistently inconsistent. The definition through the DSM-4 of post-traumatic stress disorder talks about characteristic symptoms that we're all familiar with, and it involves direct personal experience of these that involves another person's experience of actual or threatened death, actual or threatened serious injury, or even a threat to their own physical integrity. Post-traumatic stress disorder is characterized by a profound re-experiencing of the original event. Now, I slowed that down because I want to make sure that the understanding is that all of us can get pretty traumatized by an event that occurs in our life. But post-traumatic stress disorder distinguishes itself by the constant re-experiencing of the event in the form of intrusive thoughts, nightmares, flashbacks that recollect traumatic images, memories, and the resultant behavior that comes from that in terms of flattening of affect, separating oneself from others, losing interest in things, not being very motivated, and avoiding any kind of activity or a person or place or events that might be experienced or associated with the traumatic experience. The next core concept of development has to do with something that is called self-regulation. And it describes it as a cornerstone of early development that goes across every single behavioral domain. Well, what is self-regulation? A good analogy of self-regulation is the ability to do for yourself something that is going to help keep the trigger at the trigger level. Therefore, the usage of self-regulation is actually a tool that is taught. Things that will keep it at the stimulus level, keep it at the trigger level, and prevent it from going into the response pattern. The next two slides are case histories that illustrate the point of trigger going to response without interventions. The first is a 22-year-old man, and we'll call him Robert. And what we know about Robert is that he has a history of childhood physical abuse on the part of his stepfather. Now, the case begins with Robert in the day area of a local inpatient psychiatric facility. And Robert is sitting there. It's calm, it's quiet, and he's watching television. Behind Robert, out of his view, is a table, and there are male and female staff persons seated at the table. What eventually happened was Robert all of a sudden, without provocation, and we've written this, I know, a number of times in our records, without provocation, he suddenly jumps up out of his chair, huge look of anger on his face, and he jumps one of the male staff persons, knocking them to the floor. What happened next was an effort to control him and take him to the seclusion area. But what they noticed that as they grabbed him and they started moving towards the seclusion area, that angry look suddenly changed to a look of abject fear. And by the time they got him to seclusion, he was no longer responding to verbal command. He was what is called dissociating. Now, in interviewing Robert, when he was asked the appropriate question, which was, "What happened to you, Robert?" he answered, "I'm not quite sure. I was sitting there watching television, and then I thought I heard the voice of my stepfather." The voice of the stepfather was his trigger. There was nothing or no one to intervene at the level of the trigger. It ended up going to the response. This involves a 12-year-old girl. And the history you have on her is that she was sexually abused by a family member. And this went on from 5 years old up into 12 years old. In this circumstance, she's not in a psychiatric facility. She's actually in a classroom in school. It's quiet. The teacher's teaching. Everything seems to be going along very, very well. All of a sudden, one of the 12-year-old male peers leans over and says something sexually inappropriate into her ear. She suddenly jumps up from her desk, huge look of shame on her face, and without saying anything to anyone, she runs out of the classroom and runs out the front door of the school. The principal, knowing that the child lives approximately 3 blocks away, assumes that the child is headed home, calls the mother, and says that your child is very upset. We're not sure why, but she's headed your way. Mother stands on the front porch, sees her daughter coming towards her, expecting that the child is going to stop, say what's happened, but instead she runs right past the mom. The mom is now trailing her, asking her, "What's wrong? Talk to me. What happened?" She runs upstairs, she runs into her bedroom, into her bathroom, goes to the medicine cabinet where she's hidden a knife behind it, and she takes the knife out and proceeds to start cutting herself. All the while, Mom is still asking, "What happened? Talk to me." She is back at the dissociation level that we saw with Robert. Now, we don't need an explanation here, but what I want to point out in the two examples is that triggers of traumatic reminders, and you'll hear me say it all three ways. A stimulus is a trigger is a stimulus. A traumatic reminder is a stimulus. A traumatic reminder is a trigger. So all three can be used interchangeably. But the key point we want to make is that if you do not involve some degree of intervention at the trigger, stimulus, or traumatic reminder level, it will go to the negative response. The parameters that change between the state are pretty easy to see, but I want to call your attention to the last one, because that is the one that we tend to miss a lot. We know that there's a change in the affect of the individual. We know that their thought patterns change. We can see that their behavior changes. We also can see that their sense of self tends to be very, very, very low. But we quite often miss the last one involving the levels of consciousness, because to a certain degree we look at that as deliberate. The person is not responding to you because they're being defiant. And we need to explore that, because these parameters are all protective for the individual. They are, in essence, doing the best they can with the information that they have and the trauma that they're experiencing at that point in time. Now, in the emotional states of child development, we need to take a look at a couple of things that take place. We need to understand that these behavioral states that are seen are organizing. And they're organizing because they always have been organizing since the child was an infant. When we look at what happens at that point, there were no textbooks, there was no teaching of the infant, but the infant understood that if certain behaviors were shown, certain responses were given. Now, did they understand that connection? No, they just knew from a nurturing component that their needs would be taken care of. Now, these infants look at the world in that way. It's separate, it's definable. This is why they're not going to respond to every single person the same way. When they look at that caregiver who nurtures them, it becomes that caregiver and not every caregiver out there. Now, our critical task in this development is to build smooth bridges to help these kids to have the least amount of trauma interjections that we can have. And that we need to regulate that. And it's contingent upon ourselves as caregivers. Because a lot of us transfer our traumas, transfer our negativity, transfer our controlling issues onto the infant. So what is our goal? If we're going to treat the trauma, we're going to look at it from the combination of neurobiological, psychological, and social issues. We need to take into account that we want to get things back to that calm, continuous, engaged state. The unfortunate piece that we see across the country and over the world is that most people consider that to be the one and only thing that's needed to do. If you have an out-of-control situation, if the response is negative, if the person is showing vigilant, violent, or behavioral outbursts, if you just get it back to a calm, continuous state, everything's okay. And this is the core basis behind trauma-informed care, is the understanding that that is not true. I've worked in a state hospital system for 25 years in behavioral emergencies. Quite often, as soon as the situation was quiet, everyone did a slapping of the proverbial high fives and walked away as if everything was well. Well, what were they missing? What they were missing is what we all miss, is the fact that bringing it to a calm does not keep the situation from happening again, which is the second piece about preventing discontinuous states. The work needs to happen to understand why it happened to even begin with. Because if you understand how it got quiet again and work on preventing it from happening again, you then understand that in order to do so, you have to build some cognitive issues that will help that individual to make better choices. Instead of becoming behaviorally out of control, that person is then empowered with a number of behavioral alternatives to becoming vigilant, violent, or aggressive. Now, in understanding this from a neurobiological standpoint of view, we need to take a look at how our brain functions. It helps us to understand sometimes in some of the population that we work with the whys of our response to trauma. What we understand is that for every stimulus there is a response. And what we know about the stimulus response is that it's very, very quick. We don't have a lot of time between the stimulus and the response. What we want to do is we want to intervene. That's what we're here for. That's how we're supposed to be helpful. But how do we intervene so that we can keep the stimulus at the stimulus level and prevent it from getting the response? Well, there's two ways that we actually do this. One way is to use what is called social environmental intervention. That's a technical way of doing something that we've been doing since time began. Consider a situation where behaviorally the person is beginning to show behaviors that are starting to become upset and potentially going into behavioral discontrol. How many times have we walked up to that individual and said, "You look upset. Would you like to walk down the hallway? Would you like to talk?" This is social environmental intervention. And as simple as it sounds, that is the critical missing component of trauma-informed care. On the other hand, there is another form of intervention that we use that's called neuroregulatory intervention. Now, my being a practicing psychiatrist, most of the time when I'm in a situation, I'm in my office when a behavioral emergency occurs. I get the phone call that says, "John is tearing the ward apart. Can we have the cocktail?" A cocktail that they're asking for is some sort of antipsychotic agent, some sort of agent to prevent any side effects from occurring from the antipsychotic, and some sort of calming agent. So it's a triple cocktail. And my being a good doctor and wanting to come to work the next day and still work with these folks, I grant that response. And it is then given. Well, the thing I want to point out to you that the slide indicates here, and as we'll see in the upcoming slides, when you give the medication, are you preventing the discontinuous state from occurring? No. Are you helping the individual to build cognitive choices so that they can make better ones later? No. The only thing you're doing when you're giving the medication is you're medicating the response. We want to interject cognition. Cognition says, what alternatives can we help that individual to understand and to utilize that keeps it at the stimulus traumatic reminder trigger level? The third core concept of development talks about the biology, that there's an interplay between biology and experience that helps us to develop. And this is the portion that you want to pay close attention to because this helps to understand how our brain operates. We talked about a stimulus. When we experience any of those events, it goes through how the brain operates. Now, let's say, for instance, as I've done in many of the talks that I've done before, quite unexpectedly, I make a huge noise, just yell out something. Well, invariably when I do that, I'm catching people off guard. So invariably, they get triggered. And usually it's a response that is made through our startle reflex, and we jump. Most of the time, that's where it ends. We jump, and then we kind of gather ourselves together. Well, there's a lot of processes occurring when that happens. And there's three parts of the brain that are involved in that process. The first one is called the amygdala. And the amygdala is a midbrain portion organ that is responsible for fight, flight, or freeze. And in fight, flight, or freeze, that's our startle reflex. It's kind of how we design emergencies. When things happen and the body needs to protect itself, it's got options. We can run like the dickens, we can attack whoever it is that's attempting to hurt us, or we can freeze in place and let whatever happens happen. The second piece involves an organ called the hippocampus. If the amygdala is about fight, flight, or freeze, the hippocampus is about context. An example to understand context is that a signal goes to our brain, and in understanding context, it would be if I walked up to you and I stepped on your foot. If I step on your foot, there's a signal in your brain that says, my foot's been stepped on. The hippocampus is what delivers that message. However, it does not tell you why I stepped on your foot, and it certainly doesn't tell you if I'm going to do it again. It simply just gives concrete meaning to an event. So in that case, it simply says your foot has been stepped on. Finally, the third piece that we wanted to focus on was the cortex, which is the actual whole brain substance, because the connection I want to make with that one is about memory. So when we say cortex, we say memory. When we say amygdala, we say fight, flight, or freeze. And when we say hippocampus, we talk about context. Now, let's put all of that together and see how it normally functions in our body. You get a stimulus, a traumatic reminder, or a trigger. Next slide. It goes to an area of the brain that's called the sensory thalamus. And the sensory thalamus is best understood to be like a CPU in a computer. Basically, it takes the signal and it distributes it where it's supposed to go. It organizes it. Where does it send that trigger, traumatic reminder, or stimulus? It goes to an area of the brain that's called the sensory thalamus. And the sensory thalamus is best understood to be like a CPU in a computer. Basically, it takes the signal and it distributes it where it's supposed to go. It organizes it. Where does it send that trigger, traumatic reminder, or stimulus? In a very fast fashion, it sends it to the amygdala. And the amygdala is about fight, flight, or freeze. Well, when you look at the circumstance that I gave you, the example I gave you about surprising you and startling you, no one fought, no one ran away, and no one froze. And there's a reason for that. And the reason for it is that the signal doesn't just go to the amygdala. The signal, next slide, also goes to the hippocampus, which is about context. So first the signal in a very fast fashion goes to the amygdala, which is about fight, flight, or freeze. And then in a slower way it goes to the hippocampus, which is about context, and it says loud, unexpected noise. You also see on the slide that another signal also goes to the cortex, which we defined earlier in this situation as being about memory. And the hippocampus gives it context, says that it's a loud noise. Cortex is about memory, and what memory says is loud noises given to us unexpectedly in the past have not been a reason to feel endangered. And both the hippocampus signal that gives it meaning and cortex that says it's not dangerous, in a slower fashion, as you see to the right of the slide, comes back to the amygdala, and it says to the amygdala, chill out. You don't have to respond. You don't have to do anything. Now, this whole impulse, folks, are what is called normal. This is our normal response to startling. We have responses that are positive. We have responses that are non sequitur. We don't have a response sometimes because it's not necessary. We've already determined it's not dangerous. Now, what I want to do is course through the next couple of slides, so bear with me as we do this. Now, what you should see on this slide is the fact that the hippocampus and the cortex are shrunken. And where that came from is from a series of studies that was done by DeBalis a number of years ago. And what DeBalis had determined is that in children who have sufficiently and significantly had trauma, when you did an examination, which means an MRI, in this case, a magnetic resonance imagery of their brains, there were significant changes in their brains. And in the DeBalis study, which you can reference, what was discovered was that the traumas that we're talking about were all forms of trauma except physical. And I want to make that point very clear. Physical trauma was not a part of the study. So we're talking sexual, psychological, verbal. And what he determined from the studies is that the actual brain substance shrunk on these individuals. Their cortex shrunk. Well, you can imagine, like the laws of physics would define, that if a mass begins to shrink, all things inside are compressed. And since the hippocampus and the amygdala are inside and in the midbrain, they get squeezed, they get compressed. I'm showing you this slide because in the brains of trauma survivors and traumatized individuals, this is more of what the picture looks like. But how does that affect behavior? Well, let's take a look at it. Let's suppose that you have someone like Robert. And Robert, as you recall, was physically abused by his stepfather. The stimulus, the trigger, the traumatic reminder for Robert was the voice of his stepfather. It goes to the sensory thalamus, which sends it to the amygdala, which is all about fight, flight, or freeze. What I want you to also see is not only is the cortex and hippocampus shrunken here, but look at the arrow leading from the sensory thalamus to the amygdala. You'll notice it's much more bold, which essentially means that the signal from the sensory thalamus to the amygdala is much more powerful. So you're getting the strong signal sent for fight, flight, or freeze. What I do not want you to carry away from this slide is that because the cortex is shrunken, because the hippocampus is shrunken, that they do not work. They function perfectly. So when the signal goes to the hippocampus, which is about context, it gives it context. When the signal goes to the cortex, which is about memory, it gives it memory. The problem here has nothing to do with whether the cortex works, whether the hippocampus works. The problem is one of simple physics. In this situation, because the cortex is shrunken, because the hippocampus is shrunken, the signal as it passes through is significantly slowed down. What that leads to is that the amygdala has to wait a longer time before it gets the signal to shut down, which means that these individuals respond through their amygdala. They're more likely to jump up and fight. They're more likely to run out of the room. They're more likely to freeze and dissociate because the signal that tells them that they don't have to do that is slowed significantly. The fourth core concept of development talks about relationships, and this is something that whole textbooks are written about. But we do understand that the relationships and the effects of relationships on other relationships basically are how we develop. When we talk about the concept of attachment, it affects how people respond from things that have happened to them in the past. Our earliest relationships are critical in terms of our ability to regulate. But also, if those early relationships are neglectful and they're traumatic, they set up the person to respond with that degree of dysregulation in all the relationships that they get into. When you encounter individuals who have deficits as a result of these attachment difficulties, they're pretty easy to spot. Because in your interviews, what you see is that they appear to be very guarded, very anxious. Quite often, sometimes they're difficult to redirect. They are very emotional. They tend to hold on to things like grievances, things that people have done to them. Sometimes they don't take responsibility for behavior. This could easily separately be looked at as a typical adolescent perspective. But look at the next one. They tend to make mistakes over and over again. And as a result, they re-trigger themselves over and over again. They re-traumatize. They have these traumatic reminders that come back over and over again. In these traumatic relationships, they can be pretty painful for the individual. But not only can they be very painful and difficult for the individual, the second piece you can see, it's also hard for us to tolerate. And this goes down the road again of mislabeling, where we look at individuals and we look at their behaviors and we have labeled them as borderline, we've labeled them as impulsive, we've labeled them in so many other fashions because of the way they present to us. If they don't care to be trusting of us, if they care to cuss us out or all sorts of other elements, they're pretty hard things to tolerate. But what we need to be mindful about is that in the clinical relationship, their experience of trauma-based emotions are present so that we don't bring it into the relationship. So if we understand that they have been traumatized, if we understand that things have not gone in a positive way to a large degree and it is affecting how they interact with others, then we're more likely to be much more successful in our interventions with them. Fifth core concept of development involves kids being kids. They're active participants in their own development, and this reflects the intrinsic drive to explore their environment. Good way to look at this one is to take a look at any child, male child, female child, doesn't matter. But as they're growing up, things become curiosity components. I look at my granddaughter's world as being about 2.5 feet high. If I'm going to understand her exploration, I need to get down to that level and take a look at what she sees. At a 2.5 to 3 foot level, there may be a light socket that says, touch me. And we need to understand that's a very normal thing, because they're just trying to master all of this confusing stuff. So in closing, what I want to do is take a look at some take-home ideas. Look at the work environment and set it up to be calm and nurturing. So many places we've gone to, so many things we've done in terms of assessments have been cold and impersonal. And when you look at that, it makes it much more difficult and much more likely that a person is going to be re-traumatized. If they sit in a room with gray walls, with signs that constantly tell them that the rules, infractions involve loss of levels, not being able to speak with family, not being able to do anything except go to the seclusion room, you understand those are all triggers. So we need to teach each other about meticulously, not just looking for triggers, but meticulously looking for triggers. Making sure we identify, write it down, and incorporate it into the treatment when people move from a calm state to an emergent state. We need to train ourselves and others to be caring and compassionate. We need to adjust our own environment so that it can be conducive for this calm and nurturing component. And lastly, adjust what we do behaviorally. We need to take a look at ourselves and understand that how we present to others is critical in how they will respond to us. Thank you.